since a couple of you heard some of the stuff that I was talking with Aiden, is there will be a case study today, and we will use part of the time probably close to lunch where he will put it on Moodle. So you guys will have a few minutes to work that up, or a little bit of time around lunch to work that up, and then we'll discuss it briefly afterwards. Just double checking, is everybody, can everybody hear me? Good, okay. And so there will be this case study and dealing with schizophrenia. And again, we'll have it where you guys will have some time around lunch. My goal will be probably to give you about probably shortly before 11 or shortly right after 11 is that basically we'll take the morning quiz, and then we will give you some time to work on that case study a few minutes before lunch and then over lunch, and then we will talk about it when we get back after lunch. So again, it'll granted, when you're dealing with a patient, you may want more time, but this will be so we can sort of think about and talk about some of the issues that are coming there. Aiden, if you can put up the quiz from yesterday, I will go over. No, he's already done it. Fantastic. So just to review the afternoon quiz yesterday, and these are very typical type questions that you might see. I think they're a little bit better framed from than what one of my questions was yesterday morning, but that was by design yesterday morning. So question number 1, blockade of dopamine receptors in which pathway results in EPS? And the correct answer here would be C, the nigrostriatal. We're going to talk about that in more depth today. Question 2, positive symptoms are associated with which pathway? Does anybody want to make a guess on that one? It should be the mesocortical, B. And then question 3, which of the following can cause or mimic psychosis? And the correct answer to this is D as in dog, all of the above: benzodiazepines, opiates, and anticonvulsants. And probably the one that catches people the most with this list of drugs is probably the benzodiazepines, because most people think of them as sedatives and they think about using them for managing psychosis sometimes, or they've seen that happen. But we do see a paradoxical, and I did talk about that, I think, when we talked about the anti-anxiety situation there. Okay. Now, let us continue today, and we're going to get more into the drugs. We're going to talk about mechanisms of action, the pure, the pharmacology. We're going to talk about some issues, and we'll probably end up today with discussing a little bit about the guidelines. So first of all, on this slide here that we're going to start off with is this is in the perfect world, okay? You could almost plug in any drug class where antipsychotic is there. Especially, I mean, you want a drug that's safe, and we do know that safety and efficacy for a drug to be approved, it has to be demonstrated to be safe and efficacious. The FDA has to be convinced. And so one of the things is that safe is questionable. The issue becomes is that all drugs come with side effects. And so making a clinical decision with regard to which drug for which patient and which dose and so forth. When the new drugs came out, the question was, as with any new drug, is basically the issue of it being cost effective. Okay, so if I have, many of you were around when the new drugs came out, the new atypical drugs came out, and one of the things that we see, I think I misspoke, you guys. I think on that positive symptoms, I think I put mesocortical. I think it's mesolimbic. I'll double check that. So anyway, when these new drugs come out, the new brand names are always going to be much more expensive. And so I don't know if you guys have run into this when talking to drug reps or been at conferences or things like that. Um, it is a situation where that um, they can't say it's cheaper per pill, but what they do come back and say, well, it's cost effective because we have a reduction in the hospitalizations. When they are hospitalized, they're there for a shorter period of time. So there's that cost effectiveness that is presented in that sense for the overall burden of the disease. So, so the net effect here is that the the issue is when you're talking to patients, they are not going to be caught up in the fact that their hospitalization will not be as long. What they're going to be caught up in is basically how much does that prescription cost me? Okay. So that's going to be a big issue. And let me go on a little bit of a tangent right here. I told you guys I was going to do this yesterday. And there is a combination product that's available for, for antipsychotics. But there is a new thing that's come out where that one of the ways that some drug companies are getting some exclusivity is by developing combination products. Okay. And so let me give you an example of one of these or a couple of these products that have come out. So there is like 3 products that contain an NSAID, non-steroidal anti-inflammatory drug, and a acid reducer, because we know that non-steroidal anti-inflammatory drugs can cause GI irritation, and GI bleeds are a concern with people on these long term. So they've come out with a combination product, which is basically the NSAID and then a acid reducer, with the idea that the combination of these 2 drugs would produce less GI bleeds. And the companies have actually marketed these and in getting them approved by the FDA, they compared their combination product let me just pick one of them. One of them is got ibuprofen, an over-the-counter NSAID, but also available prescription, and it's mixed with famotidine, which is an H2 blocker. So the idea is that you would take this drug, you take this combination 3 times a day. The problem is that when you buy the combination drug, literally the cost of that is going to be over $1,000 for a 30-day prescription. Okay. So the 30-day prescription is going to be, now the patient is not paying that because the insurance is paying that. So one question would be, why can't you just buy ibuprofen over the counter and famotidine over the counter? So instead of paying like $1,800 a month for a prescription, you're paying probably under $20 a month. Because the company has talked the FDA into putting into the label a statement that says, do not substitute the individual components. There is no pharmacological rationale for that, but it's a way that we're starting to see some drug companies finding a way to find a niche to make money. And I think you're going to see more of these. So just on an aside, I've been called about these type of questions, and it's like, ibuprofen is ibuprofen. What the company will do is, like with the famotidine, there's like a 10, 20, and 40 milligram dose. Well, the company puts in their combination a 26.6 milligram famotidine, which is not available. So that's sort of their argument is, well, our product is, you can't get 26%, so you can't do that. So, and in fact, Rebecca, this is the big issue that's coming in here, is that the physician is writing, or the prescriber is writing prescription only, do not substitute, and they're using the label that is with the drug where it says do not substitute individual components. When you look at it, the combination drug has to be taken 3 times a day. So if you look at taking famotidine 3 times a day, you get 79.8 milligrams per day, which is, you can take 2 40 milligram tablets per day, or you can take 220s, I mean, there's ways of getting that. But this is a thing that you guys may come into, and this has just come up recently. So it's one of the things I want you to be aware of. The combination drugs, what they're really targeted for is sometimes to cut down the pill load. If you have a person that has difficulty taking a lot of pills or forgetting, the combination therapy is, or the combination pill is supposed to overcome that. But what we find is, it comes at an extreme cost. But like Rebecca, you just said, one of the issues becomes insurance companies do not want to pay for them because it is exceedingly, and a lot of docs are looking at and saying, why should my patients, even though the patients are supposedly have insurance, if the insurance doesn't cover them, then some of these companies will give coupons to reduce the cost. But anyway, it's something that's going to come up. And so since I've had to deal with this recently, I actually have to go to a hearing about this next week with one of these, with a prescriber that's using this, using in his patients his patients actually prior to the combination drug were taking individual components. So it's not like they can't take them. So, but one of the concerns that's come up, there's been a couple of editorials written out that basically say they don't understand why the FDA allowed that to be put into the label. And so that is the way some docs have been trying to justify it, because the label says do not substitute. But from a pharmacological standpoint, there is no basis for that. You can still get coverage, and there's ways of doing it. And we've had hospitals and other entities which don't carry those drugs that have called the doctor back up and said, well, we don't have this. Do you want to just give them ibuprofen and whatever the other drug is, or whatever the two drugs are. So just put that on your radar here to begin with. But anyway, going back to this general statement here, is for any drug, we would like for it to be safe. We like to have the fewest side effects, and hopefully we can, by adjusting the dose, we can minimize these side effects. Cost effective, again, with dealing with cost effective from a drug company standpoint, they can justify cost based upon reduction in hospitalization, healthcare use, and so forth. When it comes to your patient, the issue becomes, can you justify that they are going to be paying, $3, $5, $6, $8 a pill, which sometimes patients can't afford it. No drug interactions would be ideal, that it kicks in pretty quickly. You can give it once a day. Usually once a day dosing is more effective as far as, patients being compliant. And then that the pill may be effective. In this case, we would want it effective for both positive and negative symptoms, okay? So these are the properties of an ideal antipsychotic. Do we have an ideal antipsychotic? Absolutely not. We have had a major improvement, but we don't have the ideal antipsychotic. So this is an interesting chart that I've given you, sort of an overview, and actually I use this chart when we talk about bipolar too. So if you look at, on the left side, we really have two groups of drugs, two broad categories of drugs we use for treating schizophrenia. We have the older drugs, which are frequently referred to as the typical antipsychotics. Sometimes they're called the conventional antipsychotics. And what I wanted to show you here is that when you're looking at, so our first really antipsychotic that moved out here, that's not what I wanted. Let's see if this will. Our first real antipsychotic here showed up was chlorpromazine. And it showed up around the mid-50s, okay? And then over a period of time, shortly after, in the late 70s, late 80s, early 80s, I'm sorry, we basically, that's all we had were these typical antipsychotics, okay? We were trying to get better, and this is not an all-inclusive list. There's several others here. But what we found was that most physicians, and like I told you guys yesterday, when I was taking pharmacology, the conventional antipsychotics just were like the bane to me. It was like there seemed to be so many of them. There was all these different things. Some of these have dropped out. We're not seeing them used anymore. But what you saw was typically the clinicians would have a first or second choice. The first choice would be the drug they were more comfortable with that seemed to work in their patients. If that didn't work, they would shift to the second choice. And then the default drug for most of these was going to be haloperidol. So if the patient just didn't seem to respond, or just that was usually what people faulted to. But when you look at these typical antipsychotics, what you see is this. Their efficacy on the positive symptoms were not really that good. I mean, they worked. We saw some people suggested 20 to 30% of the patients responded. One of the problems you ran into is you had to increase the dose, and by increasing the dose, a lot of times you just sedated these patients really down, and sometimes people thought that was good. But they had almost any effect on negative symptoms. So we saw a response primarily on positive symptoms, but even with that, we saw that there was the efficacy was much lower. But what happened was, so you had minimal efficacy on one, hardly any on the second, on the negative symptoms. But what you did see was this was a big concern. EPS, minimum, even at low clinical dosages, there was a good chance that we would see extrapyramidal symptoms. We saw significant Parkinsonian type symptoms. We saw a lot of anticholinergic effects. And what we actually saw was the patients didn't like them. And not only did they not like them, but one of the things that they saw was sometimes these effects were disabling. Some of these movement disorders were completely disabling to these patients. And one of the things was we had, as you know, people consider it part of EPS, but sometimes people talk about it as there's EPS, and then there's the big one, tardive dyskinesia. That what you saw was that it was estimated at least about 20% of the patients that receive these conventional antipsychotics on a chronic basis basically developed tardive dyskinesia. And there seemed to be a cumulative incidence. So for every a year you were exposed to these drugs, there was an increase in incidence of 5%. So really what the problem was with the antipsychotics was trying to get control of the antipsychotic symptoms, knowing we had almost no control on the negative symptoms, but trying to get control on the positive symptoms. And the way that when you didn't get control, what they did was they tended to up the dosage. And as you started increasing the dosage, one of the things that happened is you got a greater effect DPS. So sometimes you were sitting there with trying to say, this is the best I can get with this drug. And sometimes we might switch to another drug to see if we can get a better response. But the net effect was with these older agents prior to 1990, we really were limited because the side effects became a major issue. The side effects were what would limit our ability to treat these patients. And even if we up the dosage, sometimes we wouldn't get that much more improvement or much more efficacy, okay? But then in 1990, we saw the emergence of the atypical antipsychotics. These are the new drugs. They're referred to as non-conventional, but typically they're called the atypical, okay? So what we saw in 1990, we saw clozapine was the first drug that came out. And as you know, clozapine is not a first line choice for treatment of schizophrenia because of its side effect profile. But then 4 years later, we got risperidone. Then we saw olanzapine a couple of years later. Another year later, we got quetiapine. We got ziprasidone. Ziprasidone came out, aripiprazole, and then paliperidone. So we saw this group of drugs that emerged in the 90s. And this really had people excited that we had new drugs that seemed to be working a little better. What we saw with these atypical drugs as a class was that they were at least as effective as the older drugs, the conventional or typical drugs, with regard to the positive symptoms. And in many cases, they were actually a little better. The other thing we saw is whereas the older drugs, probably with the negative symptoms, we saw some effect with haloperidol with some of these negative symptoms. But these new drugs, we saw a greater effect on negative symptoms. And that was a big plus. So we saw better efficacy. We saw them hitting the second group of symptoms. And a big thing was that there was a much lower incidence of EPS. The anticholinergic, the Parkinsonian symptoms were much lower. Now, that was almost to the extent that these drugs, many times people stated these drugs did not cause EPS. And with regard to tardive dyskinesia, there were people that were out there saying, use these drugs because we don't have to worry about tardive dyskinesia. We know now that basically EPS can occur, and we also know tardive dyskinesia can occur, but the incidence of it seems to be a lot less than what we saw with the typical drugs. And but what we did see was sort of a new emergence, I should say a new awareness, is whereas we worried about the Parkinsonian, the EPS, and tardive dyskinesia with the typical drugs, with the atypical drugs, what we saw was people were not worried about that as much, and we started seeing, though, some metabolic side effects, diabetes, hyperglycemia. To tell you the truth, we actually have evidence with some of the phenothiazines that they produce similar, they could produce metabolic side effects also. But the problem is that those things were sort of suppressed because they were more focused on the EPS and the tardive dyskinesia. Also, as we moved into the era where the atypical antipsychotics were, I think there was an increased awareness, specifically with regard to people dealing with diabetes and things like that. So weight gain and things like that, which were occurring. We saw some of those effects. Those effects were occurring back then, but again, in the earlier years, before the 90s, basically everybody focused on, if you were on an antipsychotic, you either sedated everybody too much or you gave them, movement disorders. So it is really one of those things which comes there. Arnold, you asked about how do they come up with some of these drug names. I've had that same question. I mean, there is a mechanism or things like, for example, warfarin basically was the name emerged based upon, it came from the Wisconsin Research Association or Research Alliance that was where it was developed. But some of these things that we see is, and it gets to what you're talking about, Eddie, some of this is organic chemistry issues that come up. Some of them, there will be some conventional things that is coming in there. And again, one of the things that there is this issue of creativity. You want a drug, especially with trade names, you want a drug that is, that's easy to remember. And a lot of times the chemistry can help you when studying is because the issue is that for example, beta blockers, they all in OL, most of or majority of them in OL. So that's part of the chemistry. Jason, you asked about the phenothiazines. They are used. In fact, we see some of these typical antipsychotics, in a sense, have had use. Two in particular we see is like, we do see some of the drugs used as antiemetics. We see some of the drugs used as anti-itching that are phenothiazines. You still worry about some of these side effects, but usually as an antiemetic or the anti-itching, you're going to use that very, very short term. But the other thing is going to be, we see, what's the drug? Just escaped me. Metoclopramide. Metoclopramide is actually a phenothiazine, but it's pretty much used only as a drug. So what you find is that, it gets to what you're saying, Jason, is that the using them for shorter periods of time, and as well as with a lower dosing, that reduces some of these side effects. But just to give you an example, metoclopramide, GI docs were using that quite a bit. It works very well for a condition known as gastroparesis. The label actually says limit use to, I think it's under 3 months. But we saw a lot of the GI docs were saying this is working good, especially in older patients, older women, and we're just going to keep them on them. And then we started seeing these older women develop tardive dyskinesia. And some of the GI docs were not even aware of it because they just assumed sort of that lip smacking and facial grimaces and stuff were just things that older people do. And so it wasn't too awful long ago that there was a label change that stated that individuals needed to be assessed using the Ames test. So in some of these instances where have used these for other things, because they're used for a shorter period of time and probably at lower dosages, we may not see these effects that we would see that if we were using these as an antipsychotic. So that's, I'm surprised, Jason, that somebody just hasn't, used that abbreviation COP just for crazy old people. But literally that's what, because I was involved in some of the litigation involved with metoclopramide, and in talking to some of the treating physicians, heard this. I'm treating the stomach, and the docs were really, even though they were treating the stomach, they were just oblivious that the drug could still get into the brain. That just really surprised me. Second thing is many of them were not paying attention to the label. They were not aware that there was the recommendation not to exceed 3 months, because the longer you're on the drug, the more likely you are to develop these conditions. So we just saw where people were so tunnel vision, they just said, well, I'm not treating, schizophrenia. It was almost like that the tardive dyskinesia occurred as a part of the schizophrenia. But we did see people reporting that individuals were developing, tremors and EPS symptoms. But again, the docs were just attributing them to age. So we did see that. So what we've seen with this is literally these antipsychotic drugs, the newer drugs, have really changed our ability to treat these diseases very positively. But at the same time, it has almost developed a complacency. Like I said, many of the people that are prescribing these drugs do not think tardive dyskinesia can occur. Almost believe the same thing with EPS. So one of the things, has been educating people that yes, and sometimes the picking up of these things has been by the psychologist, not by the actual prescriber. The other thing which we have seen that individuals have become more aware of, and again, this was probably because of lawsuits, is, I don't know if you guys remember, but there were several lawsuits with several of these drugs, mainly because of the hyperglycemia and the diabetes. We also saw that a lot of these individuals put on weight, which could contribute to the hyperglycemia and diabetes. So with the lawsuits, we probably got more emphasis on these metabolic side effects. There was even, it was interesting, I was in a panel discussion and we were talking about these metabolic side effects. And on the panel, I was the pharmacologist. There was a psychiatrist from Harvard, and there was a diabetologist from Texas. So the psychiatrist, his statement was that these atypical antipsychotics, while they were much safer and better drugs, they carry significant side effects, which therefore, his opinion was that the only people that should ever prescribe these should be psychiatrists. And that created a debate with regard to the diabetologist. Fortunately, I could just sit there and watch this. So the psychiatrist said these should never be prescribed by general practitioners or anyone without a psychiatry degree. The diabetologist, who works in rural Texas, was stating that, many of the patients that come in are being prescribed by general practitioners. His concern was the diabetes that was showing up because the population that he was dealing with were susceptible to diabetes anyway. Then you throw these drugs on top of it. And the psychiatrist promptly said, well, the problem is that you and your colleagues are not aware of these of the consequences of the side effects. But interestingly, then he got into the discussion, we don't have as many psychiatrists that we can get these patients to. And the psychiatrist responded, we have no problem. His response, actually, he and I responded at the same time. There's a big difference in the patient demographics that you're treating around where this psychiatrist was practicing was around Harvard. So he was dealing with middle to upper middle class patients versus rural Texas. And the diabetologist shot back and said, are you monitoring for diabetes and so forth? And he says, well, we don't monitor for that, but we tell them they should be done. So they got into a little debate about that. So ultimately they came to an impasse, and the psychiatrist recommended that for every patient that comes in, this diabetologist that came in that was on an antipsychotic, he should be getting a consult with a psychiatrist. And the diabetes guy responded, if I request a consult on every one of these patients, then it's going to create a problem with the organization that hires me, because it means basically every patient I'm having to pay and refer to get a consult. So it was a big, interesting discussion where both of them were sort of focused into their particular practice, and were saying everybody should do the same thing and not recognizing the diversity of the practices there. So when we're looking at these drugs, this chart here just gives you some of the trade names. Of course, many of the drugs now, these are the typical antipsychotics. I'm not asking you dosages, so you don't have to worry about that. But basically, we see dosages anywhere from, 5 milligrams per day. I think that's per day. Like with haloperidol, to up to 800 milligrams per day with pyridazine. When I was going through pharmacology, I was seeing this transition. And one of the things that I was seeing is that the patients that many of them were started on, one of these early drugs, one of these conventional agents, but especially if they were older or they were more agitated, we almost all the time saw them put on Mellaril. And the reason they were put on Mellaril was because it was so sedating. So especially with older people and in institutions, we saw a lot of Mellaril being used. It was generic at that time, so it was cheap. The new drugs were just emerging. We didn't have a lot of, we didn't have, in the night, it was the 90s where we saw that Clozaril came out, but really it was, about 3 or 4 years later before the other drugs came out that were being used. But again, these are just ranges of dosages and the different drugs and their trade names. Again, it's more for your reference than, again, I'm not going to ask you to memorize, or I'm not going to give you any questions that say, is this a large dose or whatever. All right. Now, these next few slides, what we're going to do is we're going to talk about the typical antipsychotics. These are the older agents, okay? Chlorpromazine, thioridazine, mesoridazine, haloperidol, fluphenazine, thiophanate, molindone, Moban. All right, so these drugs, what is characteristic about these drugs is really this. Their main therapeutic efficacy from a standpoint of treating the schizophrenia was the fact that they block dopamine 2 receptors, okay? That is their major therapeutic action, okay? Now, there's going to be a lot of these drugs we refer to as dirty drugs because they affected a lot of other different neurotransmitter systems. And those effects on those other transmitter systems created problems because that created side effects, okay? But all of these typical antipsychotics, so get this in your mind, is basically these are all acting primarily by blocking dopamine 2 receptors. All right. So they block dopamine. Let me get a different color pen here so we can. Well, it's not allowing me to change it. They block postsynaptic dopamine receptors. Now, this includes all dopamine receptors, okay? But what we see is these drugs have a higher selectivity for these dopamine 2 receptors. That seems to be the big issue. All right. So the problem is we want the D2 selectivity specifically in one area of the brain, but there is no way that this drug is only going to hit those receptors. The only way we could do that would be as if we injected the drug directly into those areas so that there was no drug hitting any of the other dopamine. And those others, especially the nigrostriatal and the tuberoinfundibular pathways, they got dopamine there. And having dopamine there basically means that, or they have dopamine receptors, which means that they get blocked also. That's our problem. So we want the higher selectivity for the dopamine receptors is good, but the fact that it's still, even drugs that have high selectivity can still affect the other dopamine receptors. And that's where our problem emerges. So if you look at this, this dopaminergic tract, these are the 4 tracks that we basically talked about yesterday. So I want you to just focus on the dopamine tract. And really what I want you to do is to focus on the dopamine antagonistic effect. It's not important to me that you know these other things here. What I'm going to do is basically, I want to just relate the dopamine action with the dopamine effect. Okay. So if we block, so in the nigrostriatal pathway, if we block the dopamine receptors, then we get movement disorders. We don't want that. Jump down to the bottom. If we block dopamine receptors in the tuberoinfundibular area, then we get galactorrhea and amenorrhea. We don't want that. The two tracks which we really want to target is basically what we want to look at is the mesolimbic and the mesocortical. But so theoretically, if we affect these dopamine receptors, that can either relieve psychosis. But remember, one system is hyperdopaminergic and one is hypodopaminergic. So when I use the term dopamine antagonist effect, we may be talking about interfering with the dopamine track or interacting with the dopamine track. Okay, so stick with me here. Ideally, we want an action to try to reduce the psychosis, and we want minimal side effects. So what we've done is we've divided these conventional agents into low potency, high potency, and medium potency. And so what we find is the low potency drugs, low potency you would think of, if it's a low potency drug, I'm going to need a lot more. So typically what we see is the drugs that fall into low potency here are these drugs, chlorpromazine, thioridazine, and misoridazine. They can interfere. I'm not going to focus on the neurotransmitters. We'll touch on some main issues here. So you have to use fairly large doses with this. In order to get an effect, since they're low potency, you need more of the drug to get to the dopamine receptors. The downside of these are these low potency agents means that they're not going to bind to the dopamine receptor as strong, but they also may interfere with other transmitters. And that's in fact what we see. Typically, these low potency drugs are going to interact with the cholinergic system and the histaminergic system. So a lot of these low potency agents can relieve the psychosis, but they come with the side effects. And the side effects are primarily anticholinergic and antihistaminergic. Okay? Now, in addition to those, we're going to get those dopaminergic effects too, the extrapyramidal symptoms. But being a low potency agent, what we find is there is less EPS with them. So the more potent agents are going to produce greater EPS. But what we see with this now, with these drugs, are one, we see the antihistaminergic action, sedation. We see dry mouth, that's anticholinergic. Constipation is going to be anticholinergic. The orthostasis, what we see there is that they may be a little dizzy when they get up. The sinus tachycardia. These actions are primarily due to the anticholinergic and antihistamine. The EPS is primarily due to the dopamine blockade. So one other thing which I don't have listed here is when you have an antihistamine action, that can cause you to put on weight. Blocking the histamine receptors in the brain can stimulate appetite and cause weight gain. So we can include weight gain on this also. So the low potency agents, they gave us the advantage of less EPS, but there is a dose-related effect that as we start to try to get more actions, more antipsychotic actions, we're going to get more anticholinergic and more antihistaminergic actions. So these low potency agents, we had less of an event, less of an issue of EPS, but we also didn't get as strong of as an action. So we did see that they were effective for positive symptoms. That was the dopaminergic action. We saw that they were sedating, and sometimes that was looked as an advantage. Sometimes it was a disadvantage, but they were less EPS. And you could actually, when I've got cheap there, when I put these slides up, I was wanting to emphasize when I use these that these were dirt cheap compared to the new drugs, which are much more expensive. But now that we have generics, we find that these, the economic issue may not be as great. The downside of these drugs were anticholinergic. Heart rate went up. Basically my mouth got dry. I may have difficulty urinating and going to the bathroom. No effect on the negative symptoms. These low potency agents really didn't have any effect on them. We could get tardive dyskinesia. This occurred less than with the higher potency agents, but it could still occur. A lot of people didn't like these because it meant the way they feel. They just said they were unpleasant. And some of the side effects, actually, a lot of people would think like that sometimes the sedating and the weight gain and stuff like this, those type of things, some people would say they could cause depression and that sort of thing. That's an issue. Arnold, the question you asked, let me back up because I answer the questions. Let me start with Maribel. She asked the first question. So what we see is when drugs have antihistaminergic actions, we tend to get weight gain, okay? There may be some other actions with the actions on the tuberoinfundibular pathway. We'll talk about weight gain a little bit more, but generally what any antihistaminergic, when you've got drugs that people are on antihistamines for long term on a regular basis, that tends to increase weight gain. Abdullah, the orthostatus and the sinus tachycardia. The sinus tachycardia can be due to the anticholinergic action, but many of these low potency agents also, I'm glad you mentioned this because I forgot to mention it, also block the alpha receptors, and that can relate to that can produce the orthostatic hypotension. Sometimes if the heart rate is kicking up too fast, that will contribute to the orthostatic hypotension. And then Arnold, your question was, can you give appetite suppressants to counter the effect? In theory, you can. In reality, many of the appetite suppressants are short-term, and you're throwing another drug on these, and these drugs may often be stimulants, which could make it worse. What you typically are going to do is, and this is with all the antipsychotics that may be weight gain, I hear a lot of people try to use non-pharmacological methods to try to manage this. So what you do is you basically try to counsel them with a dietitian or try to watch their weight by weighing them on regular visits. Try to keep them exercising. On some of these drugs that may cause weight gain may be especially profound, something like Zyprexa, that some docs would not put them on those on olanzapine unless it was a very active person, and that was less likely. But pretty much most people will gain weight on all of those. The big concern is the appetite suppressants is you're adding another drug in there, and you're adding a drug that many times may be potentially a stimulant. So that's an issue that's there. So the big advantage of these low potency drugs was that the side effects tended to be a little less than drugs that had higher potency. One of the biggest things people were trying to avoid was the EPS. So that's one of the biggest issues that you see people trying to get around. Let's go to the opposite end of the spectrum, the high potency agents. So with the high potency agents, you don't use as high a dose. So we use lower dosages because it doesn't take as much. The nice thing about the high doses is we had less anticholinergic and less antihistamine action. So from that standpoint, is we probably had the less of the anticholinergic or less antihistamine activity. That is weaker. It doesn't say none. Okay. We also have the alpha blockade activity going there too. So these would have that. But the problem with the high potency agents is right here, is the high potency agents are going to have a higher affinity for the dopamine receptor, which means more likely to get EPS. So with the high potency drugs, you try to keep the dose low and you try to get an effect prior to seeing any signs of EPS. So the advantage, just like that, they disappeared. The advantages were just like the low potency. They did have some efficacy for positive symptoms. One of the big things about these high potency agents, they were less sedating. Okay. Sometimes sedation can be good. Sometimes sedation can be bad. If somebody's having a lot of negative, having some of these symptoms, can't sleep, maybe very agitated and stuff like that, the sedation may be a positive. On the other hand, if somebody is trying to work and do things like that, you want less sedation there. When these drugs first came out, we did have some injectable forms. The other drugs, we didn't have injectable forms. So that was an important. And the drugs were there. But a big advantage was this was one group of drugs which we did have an injectable, and we did have a long-acting injectable form that was there. Now we know, and in fact, when the new drugs came out, the atypical drugs came out, some of these drugs still had an advantage because we did have an injectable and we did have that. But now you know that we do have injectable forms of the newer atypical drugs. The downside of these, the biggest issue was more EPS and a greater chance of tardive dyskinesia. Just like the other drugs, very little effect on negative symptoms, and some of the symptoms could be very similar to what you might see with the negative. So biggest advantage with the high potency agents is less sedating, but you also ran into a situation where you were more likely to get EPS and tardive dyskinesia. And then let's cover this slide, and then we will take our first break today. So we have the intermediate or medium potency agents, which was basically Navain and L'Occitane. Again, don't worry about dosages. So they fall in the middle. So what we saw was they didn't produce as much sedation and anticholinergic actions than the low potency agents, but they had less EPS than the high potency. The bottom line was most of these drugs were, because they were intermediate potency, most people used them more in augmentation of the other drugs. So this was sort of the second line drug. We didn't often see them started off on these particular drugs because even though the side effects there, the overall potency and everything was a little less. There was a question as to, some people suggested these drugs were showing work on negative symptoms. That may actually have been because the side effect profile may not have produced quite as much effects that you would think as that may have represented the negative symptoms. So again, these drugs really were never, in most instances, never first line. You either went with the low or the high potency agents. The low potency agents may be if the individual didn't seem to have a lot of symptoms, try the low potency, and if they manage the side effects, that would be fine. If that didn't go, you would go with a high potency, or if you had somebody coming in with really a lot of symptoms, and you might start with a high potency and watch out for EPS. So when you look at the overview, very similar to low potency, a little less sedating. So that originally the idea was if you had too much sedation with the low potency, maybe try the intermediate potency. They still produce EPS. They still produce anticholinergic. They also have some antihistaminergic, and they can still produce tardive dyskinesia. So just to summarize, whether we had low potency, high potency, or intermediate, most of the effects were on the positive symptoms in those drugs. Minimal or questionable effect on the negative symptoms. High potency versus low potency. Low potency, more anticholinergic, antihistaminergic than the high potency agents. With the low potency agents, there's less chance of EPS and tardive dyskinesia. High potency agents, you had less anticholinergic, less antihistaminergic, but a greater chance for EPS. So there was where clinicians basically, that's one of the big problems with only having those agents, was really a situation where that trying to get an effect without getting EPS. And since tardive is usually irreversible, and also some EPSs could be irreversible, that was always a concern. And, when you look, many of those EPS symptoms could create some major disability. Disability. The sedation could interfere with whether the person could work or not. So it was really one of those hardline clinical decisions. And like I said, a lot of prescribers would pick one low potency and one high potency agent, and that was what they would go with. And sometimes if they started with the low potency and they weren't responding, they would go to the high potency. Or if they started to the low potency and it was creating too much sedation, they would go with a high potency. Still had to worry about weight gain. Weight gain tend to be more of a problem with the lower potency drugs because they had more antihistaminergic. But it was really, one of the problems with the antipsychotic drugs is really difficult to manage patients with the drugs we had. A lot of the side effects patients or their caregivers would think was worse than the disease. When the person was on maintenance therapy, they weren't being, their mood was stable, but on the other hand, if you're dealing with an older person, you have to worry about them falling because of the orthostasis. If you're dealing with somebody with a heart problem, you got to worry about, them having a serious arrhythmia. Individuals that were too sedated, couldn't work, interfere with their daily lives. These were all issues that came into play there. All right. So let's take our break. Let's come back at 1:15. We're going to then go into the atypical antipsychotics, so these new agents. And Aid and I will get the answers to those quizzes to you in a little bit. So I'll need to pull those up and take a look at them there. Okay. All right. So we've got some weird stuff going on here. Okay, so with the atypical antipsychotics, these are the ones that we see. Actually, what has been interesting has been that probably the biggest advertising campaign really came with Abilify and was really more of its use as a it was advertised mainly for bipolar. And these others have not had such a big advertising campaign. We'll talk about that a little bit more from a standpoint of when we talk about bipolar with regard to misdiagnosis and things like that. But basically, again, I'm not asking you doses, but we do see some instances where that people have exceeded the maximum dose. That would, of course, be off-label. But let's talk about their mechanism here and how they differ. So very similar type. My screen is doing some weird stuff here, so bear with me here. There we go. You guys are seeing my screen, is that correct? Just wanted to make sure.
Yes.
Okay, thank you. I thought I had still left it there, and it seemed to be. Okay, so if you think about the one I showed you earlier, we had the typical drugs. We just had the D2 receptor there. So here's the big difference with the atypical antipsychotics, and that is that these drugs, from their therapeutic mechanism, basically focus on the fact that not only do they affect the D2 receptor here, but we also have a serotonin 2 antagonistic effect. And this fits in with the thing that we talked about yesterday, okay? When we talked about the interaction between the serotonin and dopamine systems, this is one of the big things that we have to be aware of. So from that standpoint, what we're going to do is we're going to take a look at these different drugs and see how this interplays with regard to their action. So to sort of summarize, the atypicals, they block the postsynaptic dopamine receptors, just like we saw with the others. But here is the key point, is they also block the serotonin 2A receptors. This is where that we see probably a better efficacy, because, and also probably at least some action on the negative symptoms, which we weren't seeing too much of that. In fact, to get the effects, we usually got more sedation on the other drugs, which some people thought maybe affected some of the negative symptoms. I'm not sure on that. But what we did see is that it's the combination of the serotonin 2A blockade and the dopamine blockade that gives these drugs the benefit. So one of the things I want to point to you is when people do, I'm not asking you to look over these or to memorize these. I'm not going to test you on these. However, on some of the case studies, it might, you might be able to use some of these actions. Whenever drugs are being developed, now what they do is they actually, what we basically see them doing is we develop a receptor profile on these drugs. We can do that now. When I was coming through and learning pharmacology to begin with, we were doing these mainly in animals. Now we do this a lot of in vitro. We can do receptor binding assays, and we can understand these actions with there. So if you look at these drugs that we have on this figure here, we got quetiapine here, we got clozapine up here, we got olanzapine, risperidone, and ziprasidone. Okay, so this sometimes gives us some indication of some of the side effects the drugs may have. So what we find with all three of them, we find characteristically we have the dopamine 2 receptor blockade on these. So all of them are going to act with dopamine 2 receptors. That's going to all be there. And then each of them have a little bit of D1 activity. Haloperidol has a lot of D2. Remember, haloperidol is going to be our classical, or I should say conventional or typical drug. So from that standpoint is we're going to use it as a comparison, okay? Now, the other thing we see is, notice that with haloperidol, we have a little bit of serotonin 2A blockade, but when we look at these other drugs, we see really much more significant serotonin 2A blockade, which is one of the things that stands out about these versus conventional agents, okay? Now, the other thing we have is we have histamine actions. So haloperidol, we have very little histamine actions, but we do see histaminergic actions in with quetiapine, clozapine. We see it with olanzapine, ziprasidone has hardly, we don't have any of that. Very little H1 actions, if there's none reported. We see a little bit with risperidone. And then the A is the alpha blockade. The M is muscarinic. So we would expect olanzapine to have more muscarinic actions than, say, one of the others. So that may give us some of the subtle changes that occur between these particular agents. So when we're looking at these Maribel, is we're looking at serotonin blockade, and we're looking at, it's not necessarily decreasing serotonin. What it may be doing is we're going to look at the serotonin blockade as it relates to the dopaminergic system, which we talked about yesterday. Okay. And again, I'm not going to ask you on any questions from this slide here, but it will help you sometimes look back to see how some of these drugs may vary or may differ somewhat. All right. Now, what we're going to do is go back and we're going to sort of review and put into perspective. We're going to review these dopaminergic pathways I talked about yesterday and suggested you guys take a look at them last night. So we're going to look at those and we're going to put it into perspective with regard to the drug actions, these atypicals. So in the mesolimbic pathway, what we see is by blocking the dopamine receptor with antipsychotics, what we find is that we get a greater action of dopaminergic blockade than we do of serotonergic blockade. And so that results in reducing the positive symptoms, okay? So what we find is that the receptor, what we see in different parts of the brain is sometimes one receptor system is more sensitive. So in the mesolimbic pathway, what we have is that the dopamine receptors are more sensitive to block, okay? So we find that the antipsychotics are more robust than the serotonin 2A. So we have better dopamine blocking in the mesolimbic pathway. And that's why we get the reducing the positive symptoms. All right, in the mesocortical pathway, so what we find is there's where we have that deficit, okay? So the mesocortical pathway is associated with the negative symptoms. The mesolimbic is with the positive symptoms. So when I flipped that around this morning when we were talking, just correct that, okay? I think we corrected it in the little chat board. All right, so in the mesolimbic activity, in the mesolimbic area, we have hyperactivity, so we want to decrease that, so we block the dopamine 2 receptors. In the mesocortical pathway, where the negative symptoms are and the cognitive symptoms are, basically there seems to be a deficit of dopamine activity. And so one of the things that we have to worry about is if we block the dopamine receptors, that can make it worse. But what we find is this. In the mesocortical pathway, what we see is there's more serotonin 2A receptors than there are dopamine receptors, which basically means that the serotonin system is going to be more sensitive to blockade. So if we block the serotonin receptors, and that's more profound, then basically it's suggested this may produce or may help with the negative symptoms. So what we have here is you see in this first panel, we have a dopamine deficiency. So it's a hypodopaminergic area. And so these first two panels, there says there's a primary dopamine deficiency and a secondary dopamine deficiency. But the net effect is by blocking the serotonin. So the reason it's secondary is because serotonin is stimulating these receptors, and that is causing less dopamine activation. So we're having less release of dopamine from the presynaptic receptor, and we're having stimulation of serotonin 2A receptors on the presynaptic, which shuts down dopamine levels too. So what happens is that if we were to block that serotonin, then that would increase dopamine release. And by increasing dopamine release, we would get a increased dopaminergic activity. So that is what has been suggested is actually why these drugs work, is that basically is that we have in the mesocortical pathway a dopamine deficit, but by blocking the serotonin receptors, which seem to be more sensitive to the drug because there's more serotonin receptors, this causes an increased release of dopamine. So therefore we correct that hypodopaminergia, okay? This is another area when when you guys take another break, I want you to look back over this to make sure you understand it. If I need to go back over it, then we will. Okay, now that's the two therapeutics. So with the new agents, we find that from a therapeutic standpoint, and you can sort of see it in the background of this slide here. So the dopamine activity up in the mesolimbic pathway is blocked. The dopamine deficiency in the mesocortical pathway is enhanced, so that comes up. So that means we correct the positive symptom pathway, or we act to correct part of it, and we correct part of the negative symptom pathway. What about the potential for the side effects? Well, one of the things that we find is that in the nigrostriatal pathway, the dopamine blockade is what causes the EPS symptoms, okay? So what we do is that basically by blocking those receptors, that causes the movement disorders, and it can cause it either the Parkinsonism or it can cause the hyperkinetic, such as tardive dyskinesia. So how do the atypicals work here? Okay, so in the nigrostriatal pathway, again, the serotonin 2A antagonist, by binding to the serotonin 2A receptors, they block the release of serotonin and they cause more dopamine to be released. So that reduces EPS. Notice it doesn't say it completely prevents the EPS. But this is the reason that we have less EPS with these atypical drugs. It's because of the serotonin 2 antagonism that blocks the release of serotonin, which takes the brakes off of the dopamine system, which allows more dopamine to be released. So that means that we have less chance of EPS or less EPS in general. In the tuberoinfundibular pathway, what we find is that if there's increased activity of this pathway, that prevents prolactin release. So when we use one of these drugs, basically what we're going to see is that we get galactorrhea by blocking the dopamine 2 receptors that releases the prolactin, and it takes the brakes off, and we get the galactorrhea and the amenorrhea. So what we find with these drugs is that dopamine blocks the release of prolactin, but the serotonin 2A causes release of prolactin. So by blocking the serotonin 2A, they basically, you're blocking the dopamine and the serotonin 2A, which inhibits the prolactin release and therefore inhibits the galactorrhea. Okay? So, what we're seeing is the big difference here is the serotonin 2A antagonism is offsetting the dopamine blockade in the systems where we don't want it. Okay? So in the systems where dopamine blockade, the nigrostriatal and tuberoinfundibular, we don't want dopamine blockade because that accounts for some of the effects. There's no way we can get around not having some degree of dopamine blockade, but by adding in the serotonin 2A action with these drugs, it offsets the dopamine blockade. And then in the mesocortical system, we already have low dopamine, and what we find is the serotonin 2A actually improves dopamine release. So it's this serotonin 2A that really looks like it's offsetting the dopamine blockade. Okay? Now, what I want you guys to do is we're going to back up a little bit. I want you to take about 5 minutes. We're not going to go off anything. I'm just going to mute for about 5 minutes. I want you to look back over these slides and make sure that you're following it. Okay? So let's take about 3 or 4 minutes. If you guys will just look over the last couple of slides and see if that in fact is, if you have any questions. I'm just going to mute while you guys look at it very quickly. All right. So again, I will go over this probably another time with regard to that. Um, so Brady, with regard to your question, is basically on the mesolimbic system, we're getting dopamine. We're actually getting dopamine blockade in all four systems. All right. So there will be the drug binding to the dopamine receptors, but the difference is in the um, so in the ones where you have the hypodopaminergia, what you're getting is the serotonin is stimulating more dopamine release, and um, in the nigrostriatal and tuberoinfundibular, what you're doing is you're actually producing more of a you're actually stimulating dopamine in those areas by block through the serotonin mechanism. There's no way that the drug's going to bind to dopamine receptors, but we find in the other systems there is less dopamine receptors, so there's less for it to bind to. So if you increase the amount of dopamine being released, it sort of competitively overcomes that. So it's almost like a functional agonism, if you will. So the serotonin is, so the pathways that you're looking at is in all four. So you have these serotonergic pathways, serotonergic neurons that are coming from the raphe nucleus are going to impact all of these different pathways. So the serotonin neurons are impinging on the dopamine neurons. And so wherever there's a dopamine receptors, there's the potential for these drugs, because they're dopamine blockers, to bind. But the difference is that you have a lot of dopamine receptors up in the first one, in the mesolimbic system, so you get a much greater effect. The serotonin effect is minimal, but it's more prominent in the other three systems. So the drugs block dopamine receptors, but in the mesolimbic pathway, there are more dopamine receptors, and those receptors seem to be more sensitive to the blockade by these antipsychotic drugs. And so now, Eddie, bring up another point, is that from a standpoint of with serotonin blockade, yes, if you get too much serotonin blockade, you can get depression. That can be a side effect of these drugs. This can be part of the negative aspect, the potential for negative symptoms that can occur. So it's all a dose-related effect, and ultimately by blocking too much serotonin, you're going to have that aspect. So there's where you're trying to get a balance by using low dosages and balancing with each patient, trying to get the effect with regard to that. Okay. So remember, with any system where we have the potential for, where we're blocking or stimulating receptors, if we get too much, that's an extension of the pharmacology. So if you get too much, you can get a side effect due to the excessive blockade. On slide 80, let's see, are you talking about, let me go back here. Is this the one you're talking about where it says in the mesic limbo pathway? Oh, you mean 81? Okay, those slides are really taken from what we talked about yesterday. So when I went through each of those, so all of these that have in the background, these are the same slides that I went through yesterday, just talking about the pathophysiology. So what I did was just highlight the area from the pharmacology. So if you go back to yesterday, that should take care of it, okay? Probably in retrospect, I should have kept it not blanked out and just left it there and highlighted it, those areas there a little better. All right. Now, let's talk about a couple of the other things. So this sort of gets into some of the questions that you guys were talking about here. So one of the things that we see is that the binding that occurs with most binding, especially transmitters, remember back to general pharmacology, what we have is a situation where that basically the transmitter gets released, and it binds to the receptor and then releases. It's a reversible binding, okay? With most drug action, 99.9%, that's the same situation. When we put a drug in there, that drug, the way I describe it to my pharmacy students is, it's like the drug walks into the room, walks over there, slaps the receptor, then walks to the next receptor and slaps it. So it stimulates the receptor, but it's not hanging there. Or, you have some drugs that'll go in there and they're like, Aunt Joan or whatever. She comes in there and she hugs the receptor. So she hangs on to it just a little bit. Then she releases and goes hugs the next person. So what we find is that affinity is really an assessment of how long it stays on the receptor, but ultimately it releases it, okay? What we have found out, especially with extrapyramidal symptoms, there seems to be an association with that as you increase the affinity, in other words, going from a slap to a hug and to maybe one of these, hugs and don't want to let you go type thing for a while, that sort of thing, is that the greater the affinity for the dopamine 2 receptor, the more likely that we see the chance of EPS, extrapyramidal symptoms. So if you look at this slide, what we have here is, notice that all of these drugs up here are atypicals, and their affinity for the dopamine receptor is less than most of the typical antipsychotics. And what we find is, for example, there's less chance of quetiapine and clozapine to produce extrapyramidal symptoms because their affinity for the dopamine 2 receptor is a lot less. So the more that the drug binds to the receptor or has a higher affinity for the receptor, the more chance you are to get an EPS. And we do see that most of the typical antipsychotics have a higher affinity for that. And in fact, when we're screening for drugs and we're looking for new candidates and stuff like that, that's one of the things that we will, take a look at, is we know that drugs that have higher affinities may have a higher chance of producing EPS. So this is a good example. This is one that was put forward to somehow describe the EPS. So what we find is, like the older medicines, getting up here, we get the older medicines like haloperidol. So it goes to the dopamine receptor in the membrane. It binds to it, but slowly releases, okay? So this would be like Aunt Joan going up to you and hugging you. You're fixing to, you've been at her house, you hadn't seen her forever. She hugs you, but just sort of wants to hang on to you for a little bit. And then eventually you pull away from her, okay? So we would say that that would be tightly bound, and then it slowly releases off. Well, what we find is that produces antipsychotic activity because it's binding to the deep receptors, but it also increases the risk for extrapyramidal. And notice they've got, the way they did, it's a little subtle thing here, but they've got a circle here, which basically, fits into that receptor pretty tightly, okay? The new atypical antipsychotics, and they use quetiapine for an example here, notice that it is going to go down to the receptor, but it's a little bit different. So if you think about it like this, if you're, if haloperidol is if you're the little skinny nephew, the aunt grabs you in that big old hug and just hangs on to you. Whereas the atypical antipsychotic, if you're the nephew that's a little bit big and bulky, the aunt can't grab quite around you. It's harder for her to hold you, so it's easy for you to pull away. So that's what one of the things is that when it's tightly bound, which means it has a high affinity for it, then it's going to slowly release off, and you have a greater chance for EPS. And if it is loosely bound, it still stimulates the receptor, so you still get the antipsychotic effect, but since it releases from the receptor more quickly, then they've suggested that in fact is that you have less chance for EPS. So that's one of the explanations that people have suggested. And I realized as I was giving you all that examples that I'm really getting to be, almost an old Southern redneck pharmacologist giving those type of examples of, Aunt Joan, like going for Sunday dinner and you hadn't seen her for a while and hugging on to you. So I may have gone over the edge there with my with my analogies. Tells me I'm getting old. So, all right. So if this is a nice little slide for you to think about, okay? So if you look at atypicals and typicals, one of the things we look at is what receptors do they basically, affect. So one of the things that we find is that if it's binds to do we want it to bind to the dopamine receptor? Yes, because we want that interaction with the dopamine receptor to take care of those positive effects. The downside of binding to the dopamine receptor is we can get EPS, we can get the galactorrhea due to the increased prolactin. And then one symptom I haven't talked about is neuromalignant syndrome, which we'll talk about. That can be a dopaminergic component also. The serotonin receptor, do we want antagonism there? Yeah. What we do is by doing the serotonin is that can work on some of the negative symptoms, but more importantly is it can offset that. But it can affect the serotonergic and it can produce side effects similar to SSRIs. If the serotonin is released and is not bound, it may actually antagonize some of those, so there can be some side effects. The ones that we really don't want generally are going to be these three down here. Is adrenergic system. If it's binding to it, especially blood vessels in the periphery, it's going to block norepinephrine, so we can get the orthostasis, we can get the postural hypertension that can result in reflex tachycardia from the reflexes. So we really don't want alpha-1 activities. The histamine, our biggest concern is sedation and weight gain. Sometimes we may want the sedation. We definitely don't want the weight gain for most people. And then the muscarinic, we really don't want those. So what we actually saw was that most of the typical drugs have pretty strong actions on the adrenergic, histaminergic, muscarinic. We still see some of those actions on the newer drugs, but not as much. So let's talk a little bit about before starting these medications, okay? All right, this is pretty standard for everything, but we always cover it when I'm talking about antipsychotics, just to go through it. Your medical history. Some key things that you want to be aware of. Are they obese? The reason for that, potential weight gain with the drugs, diabetes, hyperglycemia. So that fits in also, do we have a history of diabetes? Are they diabetic? That could make a big difference in how close we monitor. With dyslipidemia, our concern is here they have elevated cholesterol, or elevated lipids. With this, one of the things that we want to be careful about is basically that with dyslipidemia, if they're diabetic, this can increase their risk of heart attacks. Blood pressure and hypertension, again, diabetes makes it worse, obesity makes it worse, and any form of cardiovascular disease. Because of the relationship between diabetes, obesity, cardiovascular disease, we really want to be careful about that. We know most of these drugs, whether typical or atypical, can potentially cause weight gain. So one of the things we want some evidence, it's suggested that you get their waist circumference, get it at baseline, and then at least once a year. When you are seeing them, you're going to be weighing them. This is getting this information before starting the medications is very important because you need to know where they're at, and you need to make sure that if they start developing some of these things, you want to make sure that it is not the drug or it's not related to the drug. So that's a key point that comes into play there. Baseline weight, typically when we first start them, depending on how often you're seeing them, basically it's suggested that you weigh them monthly for the first 3 months. But if they're coming in more than that, if they're coming in every 2 weeks or something, go ahead and weigh them. If their weight seems to be stable, then you can drop it down to quarterly. But on the other hand, my feeling is if they come in to see you, if they're coming in for medications or whatever, just get this information anyway. You also, if you change the dose or change the medication, You want to go. You want to make sure that you're doing them monthly, because they may not be having an effect with one med. You change to the other med, and next thing you know, you waited 3 months to see them. They walk in and they ballooned up. And I have seen patients that have done that literally almost unrecognizable, that have put on a lot of weight. On the triglycerides, Eddie, the biggest thing with that is that the triglycerides can be an issue with diabetes and so forth. So we typically are just going to go ahead and get a lipid panel on them. And the lipid panel will include LDL, HDL, cholesterol, triglycerides. Baseline blood pressure, and then at least every 3 weeks. But again, if you're going to see them, go ahead and get these parameters. Now, this has been one that is, when we first saw the atypical drugs come out, there was the issue of whether these actually created, were creating an issue where we didn't recognize it. But since we now know that these drugs can produce that changes in glucose, we want to get a baseline glucose. We want to get every 3 months for the first year, and then annual if it seems to be stable. Again, this could change based upon how you feel with regard to the particular patient. So the next question becomes, and I will be willing to bet that if you are working in, if you've been working at any time with the same prescribers in your area, you could, we see pharmacists that do that. They could almost tell you who the doctor is based upon what they prescribe. So you will see that you have, many of your prescribers will be using their favorites, from a standpoint of 1 or 2 drugs that has been around or whatever. All right. So what you, in selecting it, you want to be, like we tell you all the time with any drug, you really are prescribing for a patient. You're not prescribing for a specific demographic. You're prescribing for a patient. How, looking at their age, their sex, their race, their weight. Are you prescribing, are you dealing with just psychosis and it's not schizophrenia? Are you dealing with schizophrenia, a schizoaffective disorder? If there's any history of their past response, for example, maybe you've treated them in the past and they did not respond. Maybe they didn't respond and just dropped out. And now you're seeing them again. On the other hand, maybe you were treating them and they were responding real well and then just quit getting their medicine because they thought they were good. So when you look at that, basically, if you have any indication of past response, and also with their family response, since we may have a genetic link, is sometimes that will give you guidance as to what would be a good agent to start with. Taking into consideration, special populations, whether it's pediatric, whether it's they're pregnant, those type of issues. And then, of course, we want to make sure that when we're looking at it, are there any comorbidities? For example, are we dealing with somebody that has a liver problem? Are we dealing with somebody that may have kidney problems? An older person could potentially, their renal function may have decreased. That may be, this may not necessarily affect your particular drug you choose, but it may affect the specific dose that you start with and so forth. Good medication review. You want to know what they're on. That includes prescription medication. That includes supplements, over-the-counter medication. Sometimes when you say supplements, they may not know exactly what you're talking about. So you may ask them, are you buying any things over the counter? With some of these diets and things like that, they're maybe buying these things at specialty food stores. They may not recognize them as a supplement. So you may have to use some creative questioning. What I always like to do is suggest to my students is I always suggest that they bring their supplements and things like that into let us take a look at them. And that way we can see exactly what's in them. Because there are some of these supplements that may have multiple things in them. And so we also want to know not only what are they taking, but we also want to know when they're taking it, how often they're taking it. You might want to ask them, have you, if there's been, are you taking the same brand all the time? Because a lot of times they may buy what's on sale, and or they may buy something that somebody advertises heavily, and that could change because some of those supplements may differ. The other thing is, we do have a big problem with individuals that are both with bipolar and schizophrenia that are not compliant. So one of the things that we find is that we need to know, for example, if you've had a patient that quit coming, just dropped off, we want to know why, maybe they thought they were cured. Maybe they don't like the way the medicine is making them feel. Maybe somebody has told them they don't need it. Maybe their caregiver has decided they don't want it. Maybe it's a side effect that they don't necessarily like. So maybe they forget taking their medication. There's all sorts of reasons. So if we know that there may be, reasons, maybe you have some experience with this person that was being treated for something else. So basically, we want to find out, if they get an idea of whether they'll be compliant or non-compliant. A lot of times, we may find this out very, within the first month. If there is an issue in some patients, we may find that giving a depot injection may be the way to go, may help compliance. And again, this has not been as big a problem, but in the past, one of the issues was the older typical drugs were cheap and the new drugs were expensive. And so cost could be an issue. And also we ran into, and you still may run into, I don't know if any of y'all do see this, but we may run into where that a particular drug may actually work better in this patient, but it's not on their formulary. So we have seen instances where even with generics, that sometimes a drug that may work better is not on the formulary, and that may require some additional stuff. The thing I was telling you earlier about those drugs that were being marketed and were very expensive, there was indications that some of the companies were actually, or a couple of companies actually had set up so that to facilitate they had a pharmacy or somebody that would help write the justification letter to the insurance company, which to make sure their drugs were picked up. So there's not anything really unique that we shouldn't be doing with the antipsychotic drugs. Pretty much this is the same, plan that we should do with any of the drugs that we're using. Big point is routine monitoring. We're going to talk about some specific things after lunch, but we need to make sure, are the symptoms resolving? Maybe some of them are and some of them aren't. We need to know that. We need to find out if there's any adverse reactions occurring. And sometimes it may be we can address those adverse reactions by either the way we're dosing the individual or sometimes with regard to maybe switching them to another drug. But we're also going to want CBCs, complete blood counts. We're going to do a lab test at least annually. Some patients, you may want to do it every 6 months. Some patients, maybe even every 3 months. And we're going to talk about an ECG, getting a baseline ECG. And one of the things that's going to be interesting is, I don't know if any of you guys, I'm sure some of you have an Apple Watch, but the new ones have access to do an ECG. They're designed to really try to target for what's it called, atrial fibrillation. But on mine, I can sit there and it looks like it's throwing an ECG and it looks pretty normal. But if somebody's relying on that, we may not want to do that. There is cardio. There's some things like the QARDIO, which can actually look at an EKG or an ECG. But since these drugs may affect the ECG, we want to potentially take a look at that and get a baseline and then follow up if that's an issue. All right. Let's take about 6 minutes. Let's come back at 5 minutes after the hour. I want to cover a little bit more, and then we're going to let you do the quiz, and then we're going to let you go to give you a little time for your lunch to do the case study that we'll post up shortly. Okay, so let's come back at 5 minutes after the hour. quiz shouldn't take you but about 5 minutes or so, and then you'll have the remainder of the time. So I'm going to try to maybe do another 10, 15 minutes on here. So with the antipsychotics, if you look at their, yes.
Doctor, if it's possible, I'm going to also run the attendance poll very quickly.
Sure, go ahead. That's no problem. So when you look at the use of antipsychotics, we see them used for schizophrenia, schizoaffective disorder, for a number of psychoses. One of the things that we see them also used for, sometimes used off-label for a number of type things. And one of the things that, interestingly, has been, and I actually saw this on one of the crime dramas the other night, which I thought was an interesting thing, is that, or a movie, or I forget what it was. But anyway, the thing is a person was being prescribed a antipsychotic for bipolar, and the prosecutor or something basically saw that it was an antipsychotic and made a big deal that it was, that this person was psychotic. And so sometimes we have seen these drugs used in bipolar, and but there sometimes is a little bit of a stigma when people hear that it's an antipsychotic. So when we talk about bipolar disease, we're going to talk about the use of some of these drugs also. Now, one of the things that we find is when we're starting to dose these patients, we do see that there is, most of these are going to be metabolized through the cytochrome P450. And remember that with the cytochrome is that the two big enzymes that we typically are looking for is 3A4 and 2D6. Those are the two enzymes that handle extraordinarily a large amount of these drugs. So we do know that individuals can have a genetic polymorphism with 2D6, and that can affect the dosing with these particular drugs. So it's something, again, by monitoring closely or knowing whether the person may have this would help us to potentially, dose correctly. With geriatric patients, which you will have several people that are geriatric on here, and we're using geriatric basically 65 or over, but some people consider 62. Many geriatric patients are going to be more sensitive to the adverse effects. In particular, you want to be careful that they have a lot of comorbid conditions. They can be very sensitive to the therapeutic effects, which means that you may not need quite as much. It's just one of those things you want to watch very closely. But in particular with the geriatric patients, we want to be specifically very careful about potential for falling. That is a big concern, them getting up and falling, because that can be a major issue. We also want to be very careful with them with regard to heart conditions, because a lot of these drugs not only can have anticholinergic actions, but some of these drugs, as we'll talk about in a few moments or later on today, can actually produce torsades, not tardive dyskinesia, torsades, and the EPS. And as I mentioned earlier today, one big concern is that with the EPS is that some people sometimes dismiss those as just a sign of aging. So these are concerns that we have when we're setting up a dosing. The onset of action, again, when you're dealing with this, sometimes the effects may take up to 2 weeks. We can still see some improvement, but this varies between individuals. And literally, sometimes what we have is individuals will put them on the drug, and just like with antidepressants, they have them changing the dose quite a bit. But literally, if we have not had a response by 6 to 8 weeks, basically that would probably be a good indicator they're not responding. And if they're not responding, basically, we should probably switch to a different drug. The other thing is many times we get a partial response. So the partial response, we need to find out, is it that we need to put another drug on there? Do we need to increase the dose? But again, if you're not where you want to be by 6 to 8 weeks at the latest, you should start evaluating whether to maybe make some changes. One big issue when you have these non-responders or partial responders, make sure that that the person is taking the drug, okay? Sometimes with the partial responders, we have had people that they don't really like the way the drug makes them feel, or maybe it's a cost issue. And so one of the things that may be happening is they may not be taking the drug as prescribed. They may be splitting the dose up. They may be doing some other things like that. So just be aware of that and make sure that is factored in before you make some changes. The other thing is sometimes it may not be the patient that is doing that. It may be the caregiver. So also, the other thing I would consider is the fact of, for example, is it possible that caregiver or the patient is taking something else that may be interfering with the efficacy of the drug? Another thing will be, is there a side effect that's particularly bothersome to them, and maybe that's why they're not taking it, or maybe they feel like they're better and don't really need it. A lot of different reasons that you need to sort out. So what we have seen is sort of what I indicated when we came back from our first break. The atypical antipsychotics represent probably the biggest advance in treatment since the 50s, okay? We had the 50s, and we basically saw chlorpromazone being used initially. We saw a 50 to 60% response. In the 80s, we started seeing what we call treatment-resistant schizophrenics responding. And so, you know, some of these data that have indicated there may not be a response, you need to look at, you know, what were the endpoints and things like that. But ultimately, what we see is the advantages are, as we've talked about this morning, much less EPS, emphasizing these drugs can still cause EPS. You still have clinicians, prescribers that do not think EPS occurs, but it can. And that is based upon really that these drugs have that serotonin blocking aspect. And so the things that we went through is the reason we have much less EPS. These drugs, because of the serotonin and the D2 actions, have more of an effect on negative symptoms. That's our two biggest advantages with these drugs, is that basically we see the potential for negative symptoms, them affecting negative symptoms with less toxicity as far as movement disorders. Now, this last statement has been changed. I mean, basically we have generic, that some of the generic atypicals may still be more than some of these other drugs, but what we find is that the generics have made it cheaper for the patient. We're getting away from that argument about, yes, it is cheaper for the overall healthcare burden, because again, your patient doesn't care that their hospital bills are going to be less. They're going to care about how much I'm paying for this drug each month. We also see typically better compliance, definitely better compliance than we saw with the typical drugs. And that is a big issue. And this is sort of the last slide. Let me check something here. Yeah. So there we go. When a patient is non-compliant, here's the things to think about. Poor insight. Do they think they really need it? Maybe they just lost it. You know, that's sometimes they had a psychotic episode and basically everybody loses it every now and then. And maybe that was just one thing, I really don't need it. Sometimes when they're stable, they figure I don't need it too much. On the other hand, sometimes the patient may be too sick one of my friends who's a social worker deals with a lot of these patients that really just don't understand how sick they are. I'm sure some of you have run into that too. Substance abuse and dependence. That can create a big issue from regard to, because what they're doing is using those drugs to self-medicate. You may find that side effects like akathisia and dysphoria may definitely be something, but sometimes in a patient, the dry mouth may be enough. So sometimes it may be a side effect that you think would not be a big issue. Most people would think the akathisia, the dysphoria, definitely, oh yeah, I can understand why somebody's not taking that. But on the other hand, something that may not be too expensive, may not be too bad to you, may be a very big thing to them. Let's say it's an anticholinergic with it's like these strong anticholinergic aspects, and my mouth's really dry, and I'm a salesperson, or I'm a public speaker. That may be a real big issue, or I'm having, those are just things that may be more of an issue than what you would think. I haven't experienced akathisia, the dysphoria, so to me, I don't really know what that is, but my mouth is dry all the time, and that makes it, and sometimes you can do little simple remedies. Take frequent sips of water. Hard candies, chewing gum can sometimes alleviate those type of things. Financial, and when we're dealing with financial, it's going to be an issue of financial may be the more immediate cost. Can I afford the medications? Can I afford the follow-up visits? How much does my insurance? You guys may run into this still, but I still run into situations where I'm dealing with students. The students have a limited mental health clause in their insurance, which means that they're got to be very, very careful. Financial may mean loss of work. Financial may mean having to pay to get to trips to the doctor and get out of work and things like that. The family living situation is you may have caregivers that don't want to mess with it. They would rather you just give them a sedating drug for, as I said earlier today, for grandma or grandpa, and let them just sit over in the corner and sort of sleep all day long. Some people have a stigma that they don't want somebody around their kids that's schizophrenic, or you may have a situation where you've got a comorbid substance abuse issue, or that the person tends to relapse into that. So there's a lot of different things that make this a very complex and dynamic situation. So all of those come into play. All right, so here's what the schedule is going to be. Aiden's going to put the quiz up. There'll be 3 questions. And then there is a case that is posted, I think, on Moodle. So you guys take the quiz, grab lunch, and work on your case. When we get back, we will go over the quiz. We will talk about the case. And then I'm going the rest of the afternoon, we'll be talking about side effects and issues and things like that in management. Does anybody have any questions? All right. So take the quiz, and then you can go to lunch and work on your case, and then I will see you guys after lunch. I hope you have a great lunch. And on the case, be prepared just to, I've got to write a SOAP note. You don't have to, you can write bullet points. We're going to really focus, you don't have to submit it to me, Kayla. We're just going to talk about it. So I'm going to ask your opinions and see what you guys come up with. And I anticipate that there will be some differences between the treatments that are sought. So you don't need to submit that back to me. Just have it in front of you so we can talk about it. Okay? Any other questions? All right. You guys have a great day, great lunch, and I will see you this afternoon. And Aiden, you should have gotten those answers to those quizzes.
Yeah, I got, doctor, and I'll keep this poll on for 10 minutes before closing it.
All right, sounds good. And I'm going to go ahead and sign out on this one and log back in.
Sure.
Around 1.